Okay, next up, we have a panel on the topic healthcare interoperability, barriers and solutions. Today's healthcare systems place a high priority on enhancing interoperability. Standardizing terminology and normalizing data to those standards are two fundamental issues in improving interoperability. Our next panel of experts will underline real barriers to healthcare and what can be done to overcome them. Join me as I welcome the moderator of the session who will take this discussion at length and introduce us to our panelists. Please give a grand welcome to Stephen Lane, practicing family physician and clinical informaticist at Health Gorilla. Stephen?
All right, so health data interoperability is, as I say, a very important topic, certainly in my world. Let me start by introducing myself a little bit to you, and then we'll jump in. As I said, I'm a practicing primary care physician for 35 years. I've been a clinical informaticist for over 25 years, and really focused in the data interoperability space for the past 15 years. I still practice medicine. I exchange data all the time on my patients, and have had the opportunity to work with pretty much all of the major forces shaping health data interoperability today. I have the pleasure of serving on the Office of the National Coordinator's Health IT Advisory Council for the past 5 years. I'm on the board of the Sequoia Project, which is an organization that's very much involved in supporting nationwide interoperability and serves as the recognized coordinating entity for the new nationwide trusted exchange framework that is being stood up in the coming year. I'm also the chair of the Care Quality Steering Committee. Care Quality is another entity, nationwide framework for supporting health data interoperability, and I've done a bunch of other stuff in the space as well. So what's interesting, I think, about this panel is we were not asked to celebrate the successes of interoperability, but talk about challenges, potential solutions. I want to point out to people, while it's sort of urban folklore and very popular to stand up and say, oh, health data doesn't move, you know, interoperability isn't happening. The truth is that tens of millions of interoperability transactions are occurring every single day across this country. We have numerous very successful nationwide networks that are moving health data interoperability, mostly between providers, but also there's a lot of access to data by individuals / patients, payers. There's various types of interoperability that are going on. The idea of this new trusted exchange framework and common agreement is to really provide a single on-ramp so that all these many types of interoperability can come together and be easier to access, more consistent, more secure, et cetera. So a lot is happening in interoperability, and there are a lot of challenges today. So we've got a wonderful group here on the panel who have, as I say, unique perspectives, and we're going to talk about some of the challenges and some potential solutions. So I'm going to let you each introduce yourself, just going down the line, and start with just an introduction. If you want to throw in one of your top challenges along the way, that would be wonderful.
All right, sounds good. Well, thank you, Stephen. I can kick us off. My name is Mehek Mohan, Senior Product Lead at Genentech. Louder. All right, I'll start over. My name is Mehek Mohan, Senior Product Lead at Genentech for our data interoperability and AI initiatives. Some things that are interesting within the team that I lead and the projects we work on are thinking about interoperability in the sense of data flowing from our clinical trial sites and produced and ready for filing. So those are some of our external initiatives. And then internally, how we think about structuring our data. And I think in the last panel discussion right before us, that topic came up of structured data versus unstructured data, and how we really leverage insights internally with that information. So 2 different initiatives with different stakeholders that are very, very important for our team to kind of crack the nut on. I come from a molecular and cell biology background, working in various Nobel laureate labs on gene editing, and most recently now am the Roche Genentech representative on Transcelerate, which is the largest biopharma consortium. So to kick us off with a challenge that I see in interoperability, it really does surround how we think about the flow of clinical trial data from our clinical trial sites. So I'm taking the pharma perspective here of how do we enable that flow of data to come over faster, more effectively, and with fewer transcription errors. And what we're seeing on the clinical trial site side is a real variety in data standards and infrastructure, which can cause limitations in how we think about a solution that really pulls that data in for us. And so it's not a one-size-fits-all problem, but it really is how do we customize to meet our clinical trial sites where they're at. I'll pause there and pass it over to you.
My name, can you guys hear me?
No, I don't think you're on.
Just keep talking, let it balance, okay. My name is Charles Hale, and I am the president and founder of Hale Consulting Solutions. We are a consulting firm that specializes in cybersecurity in the healthcare field. So we're coming at this from a technology point of view and how to secure data across the organizations and across the exchange of data between organizations. My organization works with the provider community. We also work with the payer community and with the government regulatory community. So that kind of gives us a little bit of a 360 perspective on this issue and the different kind of challenges that are being faced by organizations that have very different agendas within the healthcare space. As far as some of the things that the organization does, we're looking at compliance, of course, HIPAA compliance, high trust certification, things that you can show that we have made a reasonable effort in this space to be secure. But going beyond that, a checklist saying we're compliant doesn't mean that you are not vulnerable. So we're really looking at this from a risk perspective of what kind of risk does your organization have as it's exchanging data, both within the exchange with other organizations and within your own organization, so that you can really secure your data to the best of your ability and make sure that you are safe and that you are securing the private and personal information of your patients and members. Challenges. So one of the biggest challenges we see to interoperability, there are many, but coming from a cybersecurity perspective, is how do you do this in a secure space? And not only within your organization, everybody feels like the data is secure and does the best job they can to secure the information in their organization, but we see a lot of supply chain attacks. It still happens all the time, but a lot more attacks are occurring on somebody we do business with. And they're getting our data because we give it to them so they can do call services, so they can do population health. And so we're really looking at how do we secure across a whole chain of trust here so that from point A to point Z, the data is secure and that patients and regulators and everybody have trust that the data can flow freely and securely. And I will pass it on to Tanwir.
Thank you, Thank you, Charles. I'm Tanwir Hasan. I'm the founder and CEO of AIHCON. It stands for All Inclusive Healthcare Omni Network. So we have been working with multiple healthcare facilities in New York for almost last 6-7 years. And from our experience, what I want to say about healthcare interoperability that rather than swamping the process, it's more important that if we look into the purpose, why we are doing it. So all the technical barriers, technical, cultural, organizational, then economical barriers of interoperability, I think what we personally focus that it's more important to understand why we are doing it. What is the purpose of this interoperability, and how can we help the physicians and also the patients? In terms of patients, it's very important that how we can enhance the patient engagement. And in this process, I think one of the biggest challenge when we are doing it, we're trying to help the doctors, providers to deliver the healthcare properly to the patients. At the same time, it's very important that one of the major intent to do this is to help the patients, whether this is helping the patients or not. So from that perspective, I think rather than swamped in the process, it's more important for us to focus on the purpose also. So that's what I would say.
Thank you.
Yes.
I'm Jeff Lucas. My career started a long time ago in IBM and ended up in a healthcare role in Texas. And it's back when the only thing we really could sell were mainframes. It was, paper charting. But I saw this big opportunity and then ended up in roles at Oracle, started their healthcare in the mid-90s, and then went over to a company called Science Application International, who many people do not know. They built the military's healthcare system, the most comprehensive, globally deployed clinical system on the planet in the 80s. And so when I got recruited to SAIC, it was to do the commercial healthcare. We had Kaiser, and at that time, Kaiser still have 12 regions, but they had 12 disparate data centers that they wanted to integrate into one clinical data set, and our company won that project. That's where I started seeing the challenge of data coming from disparate systems. That was the interoperable challenge, and I thought this data needs to also be delivered down the line through care coordination, and then over the years have had enough experiences to see and develop a vision around how interoperability can serve the care needs of any care patient, throughout their care continuum with a disparate set of care providers. So we're really sharing that patient's aggregated health profile beyond the medical record, social determinants of health, we've heard all that. We're building an environment now where all that can be possible in a secured personal health electronic resource exchange, which we call SPHERE, and also having everybody in that care continuum be involved in that care through authorization by the patient. And then a tool that we've designed to build an aggregated set of care plans into one actionable lifestyle care plan that considers diet, rest, exercise, attitude, lifestyle, medications, and specialists. And those are all the components that we've heard everybody talk about. We're trying to bring this into one seamlessly integrated cloud-based environment that can be actionable and capture data that is reportable to any entity that wants to get insight into their patient, whether that's a family member seeing a trend that's happening before the provider or in combination with the provider. So we're really doing real-time care with real whole person-centered data. I think the barriers, which used to be technical, they're not technical anymore. With standards, I think we're able to achieve, and Health Gorilla and organizations like that are really paving the way to bring that into now the bigger challenge, which is buy-in from the organizations that may or may not want to share their data. You've got the big mega vendors, the Epic Cares, which have an attitude of global domination. They don't want to share. They don't have an option. With 21st Century Cures Act, a patient can get authorization to have that data. Now, what we're trying to build is an environment where the patient is at the center of authorizing and knowing where that data is being used. And so I think that the future really is, it's wide open. I think over the next few years with folks like yourselves in the audience here endeavoring, telemedicine, mental health, all the things we want to accomplish, I think they're going to be accomplished. And I think it's the buy-in, it's the trust we build in the way we do things. And so I think I'm excited about all the things we're going to see as an industry that need to happen. Thank you.
Wonderful, wonderful introduction. So we've got, as I say, a diverse panel. We've got clinical trials, we've got security, we've got patient engagement, we've got care coordination, just to sort of label you guys a little bit there. But very different perspectives on the challenges of interoperability. So I wanted to just, I'm going to go totally off script. I hope you don't mind.
So will we.
I wanted to sort of build on what you were saying. You were talking about purposes of use, the reason for exchange. And again, I don't know who all's in the audience, but there are some very specific purposes of query and purposes of use of data. And the purpose for which you query doesn't necessarily have to be the purpose for which you use the data. Data can be repurposed, but there are very specific purposes for which you can query. And treatment, payment, and healthcare operations are the three big ones. Those are the ones that were covered under HIPAA many, many years ago. Those are the ones that HIPAA allows you to exchange the data, and in turn, the 21st Century Cures Act, as was mentioned with the information sharing requirements, really requires you to share the data for those purposes. There are, of course, other purposes. Research is one in particular, which is not part of treatment, payment, or healthcare operations. So I guess let's start with these purposes because, of course, patients get it when you're exchanging data for treatment. I mean, that was pretty weird 15 years ago when we started this. You know, there was this whole period of opt-in and everything. But now, like, the world has moved on. Treatment is easy. Payment, a little harder because providers and payers don't always like to share data. And healthcare operations is kind of confusing. You know, that's where care coordination comes in under healthcare operations. If it's being done by a provider, if it's being done by a payer, it's actually a different category. So talk a little bit about purposes of use. I'd like each of you to sort of, you know, I'm going to go the other direction because yours is the one that's outside of HIPAA, so we'll end up there. But talk about the purposes of use. I mean, care coordination is a tricky thing. You're talking about user communities, you know, caregivers, family members, community-based social services. Payers often get involved in care coordination, providers themselves. It's a challenge. How do you see us overcoming those challenges specifically related to data sharing?
Yeah, and I think, you know, if you look at the purposes, you've got to decide what stakeholder you're talking about. If it's an insurance company, the purpose is let's lower the cost of care, right? So that I optimize my premium for the patient. And so, you know, in that regard, they want to have the data there because that's going to help make decisions that are going to be, you know, eliminating that lab that you think you need, but that data is going to be there. From a provider standpoint, you know, it may be to give me a better insight to my patient as he arrives. And I think that's one of the things that I've heard a lot from some of the provider leaders out there. They'll tell you healthcare is broken. What's the problem is people are burning out because they're getting patients. They have no idea what really is behind this problem, right? And so they're challenged with all that, and you throw COVID on top of that, and you talk about the family and the patient, and it's the benefits there are that I want quality of life. I want, you know, I've got a diseased family member that's been a problem managing their chronic disease, and I have no ability to help. And if you give me the ability to help them, I know they're okay. I feel better, quality of life, our whole overall, you know, family cost of care, lower out-of-pocket costs, et cetera. So I think it depends on, you know, what stakeholder you're addressing.
When I talk about patient engagement, it's actually a very broad term. And one thing always comes to me that in terms of patient engagement, one of the most important thing is health-seeking behavior, right? So when we are integrating multiple systems, multiple platforms, we can have 10,000 platforms, but if the patients are not using it, if they don't understand the importance of it, then we cannot get the benefit, right? So if we think all this interoperability problem as an onion model, what I always talk about, so it's kind of like if we have a cross-section of the onion, we'll see that deeper inside, the core problem is health-seeking behavior from patient perspective. So when we look at from the patient's perspective, it's how patients are reacting to the physician's advice or how they're reacting to the platforms. Suppose there are multiple platforms right now. ZocDoc is helping for making schedules and other platforms like that. But it's how can we engage these patients with these platforms so that the doctors can help communicate with the patients more. So during COVID, we understand that telehealth did a revolution. So now we understand the importance of telehealth, how the doctors can be more accessible to the patients, how in terms of any emergency or anything, the patients can reach out to the doctors. But still now, I think if we address health-seeking behavior, and for that, it's very important to address another communication method, what we call the behavioral change communication, the BCC campaigning for the patients. And that's the best way if it comes from their provider. Either primary care physician would be the best because now in value-based care model, we see that primary care physicians are the center of the care, and they are kind of capturing all the health events, all the data, and from there, if the patients are completing their referral loops, eventually all the informations are coming to the primary care physician. so that once the patient is moving from one primary care physician to the another primary care physician, if we have a better way of transferring the data from one PCP to another PCP, it helps the patient significantly. Because if we look at the data, it's almost like 28 million people are actually migrating from one state to another. And if we look at the the domestic flights in the United States, that's more than 600 million flights per year. So in that case, one of the biggest problem, even I personally faces several times, that when you are moving from one state to another, and if you are encountering any health event, you are at a loss, you don't know what to do. Because we are talking about, so that's why when I started that, rather than swamped in the process, we really need to understand the purpose. And for me, it's very important that the health-seeking behavior, right now what we have personally is a kind of sickness-seeking behavior. So all this healthcare interoperability, if that can be done properly with the BCC campaign for the patients to enhance the behavioral change communication, health-seeking behavior, so the trickle effect will be that this sickness-seeking behavior can change into health-seeking behavior. And I think then we can actually see the result. Because if we want to see a persistent result, we need a system. And for the system, we need a tool. So right now, we have a lot of experts here who are actually dealing with the technical barriers, what Jeffrey just mentioned, that we already overcome those situations now. And it's now, it's more about the cultural barriers. It's more about the health-seeking behavior. So yeah, that's what I'd say regarding this.
So I'm going to pivot us a little bit for Charles' response here. Get ready. So a little bit of HIPAA 101 real quick. So HIPAA-covered entities are payers, providers, and health data clearinghouses. They're not healthcare apps. So whether we're talking about a care coordination app for family caregivers, whether we're talking about a patient engagement app, if those apps actually are connected to a provider organization through a HIPAA business associate agreement, then the app is covered by HIPAA. But a lot of apps out there aren't selling themselves as business associates, they're selling themselves as apps, which means that they are not covered by the HIPAA privacy or security rule, but rather they're covered by FTC. So Charles, you're in privacy and security. We're talking about a lot of creative solutions here, some of which fall outside of HIPAA. So what happens to privacy and security when the data is out of HIPAA?
Well,
and how does that impact this discussion?
Yeah, and that's a great question, and one that goes beyond healthcare, honestly, that we have a very diverse and inconsistent set of privacy and security rules here in the United States. It's not an area that we've been real strong in. And yeah, HIPAA doesn't cover a lot of things because Google didn't exist in 1996. Facebook didn't exist in 1996. We didn't have cell phone apps, in 1996. So they didn't know this was going to be a coming problem. And that does create a significant challenge for us, going back to my idea of trust, is that people don't want to risk that their data is going to get out there, and suddenly they're going to start getting pop-up ads from Google saying, your doctor says you need to exercise more. Nike's having a sale on tennis shoes, well, maybe some people do, I don't. So that's one of the risks with it, and that really goes back to that chain of trust of establishing when you're trading this data, knowing that it's a reputable organization that you're trading it with. They've met certain criteria as far as certification and purpose of use, as you said, that it's a clearly defined purpose of use. We are giving you and we are sharing this data for the purpose of research, for the purpose of healthcare treatment, for the purpose of cost controls or population health, or for the purpose of advertising. That's a valid purpose, but it has to be stated and it has to be known to the individual data owners, the patients and users, that this is what their data is being used for.
Are you familiar with the Karen Code of Conduct?
Yes.
Do you want to talk a little bit about that?
Go ahead. Yes.
Okay, that's fine. So Karen, C-A-R-I-N, you can look it up, is an organization that has sort of brought together a whole bunch of the health app developers and said, hey, the only way we can really solve this problem is to self-police our industry. So let's come together and let's define what it means to be an ethical, secure, private app when you're living outside of HIPAA and in this FTC-regulated space. So check it out, the Karen Code of Conduct. I'm actually going to be working with Karen starting next week, I think, on a secondary code of conduct for the middle layer, for organizations like ours at Health Gorilla that aren't actually a patient-facing app, but are more supporting the exchange between those apps and providers, researchers, payers, and others. So it's a challenging space because we don't have really clear federal legislation. We don't have comprehensive privacy rules that really are set for this part of the 21st century. You know, even if we get them right now, they're not going to be right in 20 more years. But at least we know HIPAA's out of date. Right?
Yeah, well, and it's made more complicated by some of the states are now taking the lead, saying, okay, these are the privacy rules in California, and these are the privacy rules in Wisconsin, and these are the privacy rules in Rhode Island. We don't have geological boundaries on where our data is going and where these apps are being used. So suddenly you're having to go, okay, we have to comply with all of them? How's this going to work exactly?
Right.
So we were talking about purposes of use and the fact that research falls outside of treatment, payment, and healthcare operations, but there's a purpose of query beyond those, which is individual access services or patient requests for their own data. And there's not a clear line between a patient requesting their own data and a patient giving permission to another entity, an app, to request data on their behalf. So one of the things we're looking forward to in this new TEFCA framework, the Trusted Exchange Framework that's coming, is that one of the first priorities besides treatment-related queries is queries, individual access services, IAS queries as they're called. And we believe, at least where I hang out, that is going to really facilitate research. So talk about research, talk about being outside of TPO, as we call it, and the potential for leveraging IAS, individual access services, under TEFCA to support what you're doing.
Yeah, absolutely. It's a really interesting point, right? Because so zooming out, when you're a patient and you're going to a hospital for your normal checkup, your information is included in your electronic health record. Now, if you're also enrolled in a clinical trial, then some of that same data is going to come over to us within our electronic data capture systems. Historically, that data is not one-to-one. So even if we might be capturing weight in one way in the electronic health record, it might look totally different in the electronic data capture system on our side. So we've come a long way, and as Jeffrey mentioned, technology is really not the problem here, where we started off with paper and we finally moved into electronic systems. But right now on the site side, a clinical data coordinator, a human, is sitting there manually swivel chairing between one system and another, duplicating that data entry. And so what we started to see was that is causing significant delays in time to access of data for us, as well as quality of access. And this is where we see the query rate come in, where transcription errors run high. And ultimately, for our clinical scientists, that's not helpful for making faster decisions for our dose escalation, for instance, in early phase trials. So there are questions that we want to be answering. We want to answer those quickly and adapt quickly so that those clinical trials are most effective for our patients. So the product that we're building is kind of what I like to nickname the Rosetta Stone of healthcare, because for research speak and hospital speak, there wasn't really that translation, right? Those languages didn't really communicate. And now we're finding a way to leverage technology that already exists, application programming interfaces, mapping algorithms, cloud services, putting them all together in a unique way to automate that flow of clinical trial data. And that's really the big nut that pharma's been trying to crack for 15 some years. And there are a couple of reasons as to why that's possible now. And technology not being the issue, but the FDA, for instance, in 2018 came out with a guidance for how we think about using electronic health record data and increasing that accessibility of information for us to use that in clinical trials. And so that opened up a whole new world for us to think about new questions we might want to ask. And back to Tanwir, your point on what questions do we want to be addressing with this data? I mean, longitudinal data is big. Thinking about your work, Jeffrey, with real-world data, patient longitudinal data in, let's say, Flatiron databases, a company that Roche acquired a few years ago, that kind of information can really help us learn even more about patients. I mean, super responders, maybe specific genetic types of patients. How do we increase accessibility? And so there's so many questions that are now open for us to answer and explore with the access of this data in a much faster way that we were never able to see before. So it's a totally new environment. And then I do want to address the patient access to their own personal data. And so, of course, the way pharma works is, we're very cognizant of informed consent forms, for instance, so patients know what data are we actually pulling over. We don't want all of your data. We just want the very specific amount that is relevant to the clinical trial. So that's very, very important. And then thinking about the product that we're building, we obviously can't know which patients are, or who they are, right? We can't know their protected health information. So their PHI is information that we would never get on the pharma side. So how do we think about keys and abilities to pseudo-anonymized data, thinking about subject identifiers, for instance, so that we're not actually uncovering who this patient is and breaching that level of privacy, and also trust, to your point, right, in clinical trials, that's really, really important. So lots of questions to answer there, and then I think the last point I'll make is just around the health investigators at the clinical trial sites. So our patients enroll in a clinical trial, and it's really important that the investigators can get an understanding of how the trial is going, how their patients are doing, so that they can then adapt and think about what other types of care might that patient need outside of the clinical trial. So it's this really bilateral way of thinking about the flow of data, and all of, as you mentioned, the stakeholders are really different and equally as important in thinking about how we solve these problems and address these questions.
That's great. So you mentioned SDOH at one point, Jeffrey, and I don't know if everybody here knows that acronym. It actually stands for a number of different things depending on whom you're talking to. I like to say social drivers of health. Some people say social and behavioral drivers or determinants of health. But SDOH is sort of all that other data that really hugely impacts our health. They say that no more than 20 or 30% of your health is actually a result of your health care, that much of it is related to who you are, where you live, your behaviors, et cetera. So SDOH data is all that other data that is increasingly important to providing healthcare, to planning healthcare, but has not been exchanged or even collected in a standardized way in the past. So there's a lot of efforts going on to standardize what are the contents of SDOH data, what are the technical standards, how to exchange that data. But talk about this from a care coordination standpoint. How are you collecting and using that data, and what do you see as the challenges with that?
Yeah, well, and I know like the Gravity Project, which is very keen on trying to put their arms around what is social determinants of health. There's been a lot of debate, but it is, fundamentally it's about that patient's lifestyle, where they're, your income, your education, your zip code, and as an example of zip code, where you live might be a food desert. When you're a diabetic and you're supposed to be on a care plan that your doctor wants you to be on to get healthy food, you don't have healthy food. And maybe you don't have, people, in your immediate care circles. You might be alone. And so these are indicators that are now being captured, and we're certainly going to be including those in our SPHERE model, because those are going to be data points that can be used to really isolate, get insight into, this patient needs to have ready meals or ready wheels, and so it can help determine the needs. Well, first of all, the issues that have to be addressed. So I think they're going to be more and more involved in, and certainly this is where industry is putting their arms around it, seeing how important it is. And I've even heard that social determinants of health are more important than your genomic data. That's quite a statement, right? So it is very important. Everybody's eyes are open to it now. We've got to have, in some way, have that be part of that whole person that we're looking at.
I think the line is that your zip code is a larger determinant of your health than your genetic code.
Right.
Easy to remember.
Yeah.
So Tanwir, you're working in patient engagement. You've got apps where you want to engage patients. That, of course, provides the opportunity for patient-generated health data, for you to send a questionnaire, a survey, or get some information back. Some of that data, is purely clinical. Some of it may be social. Some of it may be behavioral. A lot of information there. how are you integrating that sort of patient-generated data and SDOH in your domain?
So when we talk about social determinants of health, so all those topics Jeffrey mentioned, so one very important thing about it that when we are pulling data, it has to be like there has to be some constants and there has to be some variables. So phenotyping and genotyping is always constants for us, right? But the social determinants of health, they are the variables. So when we are talking to different physicians, specialists, so I think the social determinant of health, when we are picking those variables, it's there is some variables to pick up those variables also. So based on that, I think it's a little bit more subjective to the specialist. It's more subjective to that caregiver. It can be because when we are talking to the behavioral health counselors, so their social determinants of health sometimes is different. And when we are talking to the cardiologists, their social, like definitely all the components of social determinants of health are important, right? But you don't want to be swamped with all the information. Maybe that's not helpful. So we need to have very targeted variables with the specific constants so that we can get the right output what we are expecting. So that's how like we are trying to generate, but there needs to be a lot of research and meta-analysis to find out those right variables for right specialists.
Right.
So Charles, continuing on this theme of the SDOH, today SDOH information is being collected in a lot of different settings.
Yes.
In the clinical care setting, in community-based settings, potentially by apps, et cetera. I've been involved in a number of efforts to try to get the data that's being collected out in the community by caregivers, social care organizations, getting that back to providers. But in that setting, they don't have all of the big iron privacy, security, apps, HIPAA that we have on the provider side. Talk a little bit about the challenges and opportunities with securing and assuring the privacy of SDOH data as it's flowing in and out of health systems.
Well, I think one of the big challenges is just being inclusive of this group in the discussion, because I think that they are left out a lot, that they're not getting the education they need, certainly not about security or in general how the data is being used. So making them aware, the number one biggest vulnerability we have in security is people. You can implement all the systems in the world, and when John Q, puts his user ID and password on a Post-it note and puts it on the side of his monitor, it's all for nothing. So it's really working with these groups to help they understand, and then working with the innovators to develop the apps to make it easy for them to implement or to get that data across in a secure manner. So it's really, it comes down to convenience and education. So making it easy for them and making them aware of what it's being used for and how to do it securely.
That makes sense. So Mehek, I want to twist it a little bit for you because, of course, in clinical trials, part of what you're doing is having patients report back. Mm-hmm. So again, this notion of patient-generated data, some of which probably is SDOH related, a lot of it is really clinical. How are the researchers who are collecting that data from the patients then sharing that data back with other members of the care team beyond the research team?
Yeah, so I want to take a standards approach to this answer because I think it's interesting to see the way our community is changing in terms of how we collect health data. So you may or may not be familiar with FHIR, the Fast Healthcare Interoperability Standards, and that are resources, and that is I think, budding form of ability for us to really capture data in a way that may be a little bit more consistent with, interoperability across our electronic health record systems, at our clinical trial sites, for instance. That adoption is starting to catch fire, no pun intended, but it's good to see that I think as we evolve in the landscape and clinical trial sites, develop their infrastructure of actually being able to capture this kind of data, we're seeing standards take place that allow for that ability to disseminate that information a little bit more easily. Not all sites are there yet, and so we do see quite a spectrum of sites that are more willing to onboard now and sites that maybe are still on paper, and so that concept of FHIR resources, let alone electronic resources, doesn't really exist yet. And so being flexible in ways to aggregate that data when it comes to us, and then being able to glean insights from it and then report back out is really, really important. But this concept of standards is one that's really exciting because at this point, one would hope that that adoption of fire resources might be more prevalent in the coming years.
And that's one of the things that I think is one of the challenges with standards too, and we're seeing it with fire already, we saw it with the other things, is there's a Da Vinci implementation of fire. There's a Blue Cross Blue Shield.
Of fire.
Yeah, just like DICOM, just like HL7, just like everything. So it's really getting to that point of maturity as an organization that we can say, okay, this is how we're all going to use this standard, rather than, well, we've got a standard, but everybody uses it a little bit differently.
Right.
One of the benefits, the purported benefits of the new Trusted Exchange Framework, or TEFCA, is that it's setting very specific standards.
Good.
So while the TEFCA framework for data exchange is going to be voluntary at first, it's going to be limited to treatment and these individual access services, it does specify a fire version. It has a very specific fire roadmap for how we're going to transition from where we are today to where we need to go. And again, it promises to be a single framework for nationwide exchange. So it's very, very exciting. I have noticed this hasn't been a super interactive audience, but I would love to give time if you guys have questions.
If I can
No, please, go jump on. But if you have questions, start thinking about them, and please come on up.
Picking up on this introduction of fire in this conversation, which we probably should have started with fire. But, fire, and I'll throw out two, structured and unstructured data, right? So in our platform, for example, we're realizing, because we have one of our key members that is, helped establish the HIPAA policies 20 some odd years ago, Dr. Dixie Baker. And so she said every piece of data,
She's great.
yeah, every piece of data that we ingest, we're going to turn into a fire resource. So we're only going to, if we get
Those that you can.
yeah, well, even unstructured,
Right.
a picture of a meal, and we can turn that into a data point, or I go to CVS, and we'll talk about CVS and where that whole market's going. But, I go in, I haven't taken my blood pressure. It knows, it tells me, hey, I've got a cuff here, stick it in, take a picture. We take that and we scrape those numbers, right? That'll be a fire resource. So everything we want to deal with, which would facilitate research, right? Because we're going to build this environment that we can also, strip the patient data, have it in a whole data set that could feed research organizations. But I just wanted to, touch on that fire, because it's key, right?
We could do a whole panel.
We
on
could
fire.
do a whole
But
panel.
look, we have Q&A, so let's do this. You want to introduce yourself and where you're from?
Sure. My name is Jessica Grunler. I'm from the Bay Area. I have been a nursing informaticist for 25 years. I've worked with Amy and all of the other organizations on interoperability. And my question, from a strictly pessimistic view or realistic, depending on where you live, is when the largest hospital corporation in America still uses a DOS version of Meditech, how in the world are we going to get to interoperability in my grandchild's lifetime?
Well, so Meditech is certainly one of the largest EHR vendors in the hospital space. I will put in a little plug. Our company just signed a contract with Meditech last month to support their interoperability on fire in Canada,
Are they still
and
on
hopefully moving that into the U.S. So I mean, even Meditech, they've got a new cloud-based solution. I mean, so it's true though. You can't force a hospital to their system. You can't force people into the 21st century. But I think the writing on the wall is very positive, even for Meditech hospitals.
I agree that it is positive, and one silver lining that we saw in the pharma space, at least during the pandemic, actually, was the site data coordinators and site resources in general were strapped, and we saw a lot of resource attrition. We saw even further delays in access to data. Quality of data was dropping, and right when the pandemic started, it was pause all non-molecule activities. Focus specifically on making sure the pipeline is moving through and clinical trials are continuing. But then we started to hear from clinical trial sites and data coordinators and investigators themselves, we need to bring back this initiative. It's really, really important that we find a better way of use of time for our data coordinators, a better use of time for our physicians. It's really important that pharma comes up with a solution, at least on the research side, to automate this flow of data, because it's taking up way too much time and it's a resource burden that we can't support anymore. So that was a silver lining that we saw during the pandemic that I think I can imagine happening again, I think, in a way that coming out of the pandemic, we really take that lesson forward. And so there's a lot more incentive to build solutions to these kinds of problems now that we've seen how difficult it was to access data at a time like when the pandemic started. So that is, fingers crossed, a good sign for us moving forward. And that's one perspective.
Question?
In the SDOH area, I'm wondering if any of the panelists have had any experience with the data that's been collected in the Accountable Communities projects. We were able to use that data in Dallas in asthma work to correlate ER visits and admissions with social determinants of health data that was collected as part of the surveys that. And also on the side of, we're talking about the challenges of integrating. I think United Health, and I'm not a big United fan in other respects, really deserves a shout out because they got the CPT code. So now in claims data, there is at least a way of counting. Before United did its work, there was no way of coding for food insecurity, screening and intervention. It did not exist in CPT. It now exists. And so at least we have the hope of being able to collect the data.
Really, really good points. And please catch me over the wine area out there. And I want to talk about some of this data that you're seeing in the community. I think one of the challenges with SDOH, unlike clinical data, which has been being standardized by HL7 and others for decades, the social data is not so standardized. So different well-meaning folks have developed various standards. And as you've heard, the HL7 Gravity Project is really trying to pull all that together and come up with true international standards for what data to collect, how to collect it, how to transmit that and exchange it. But a lot of challenges, but a lot of people have done great work. Next question.
Sure. Hi, guys. So my question is about this collaboration and interoperability, and it's about budgeting and ensuring that we're meeting these sorts of minimum standards as time goes on. And so to the last person's question around how are we going, or two questions ago, how are we going to reach these goals when we're still operating on these DOS versions, right? So, I'm an engineer from the Silicon Valley who's now in integrative medicine, so I'm looking at this from a younger point of view going, well, my experience, and especially as we're collecting patient data through things like Fitbits and Apple Watches and all the fancy detect devices, there's a lot of innovation in Silicon Valley that's being driven towards these individualistic data gathering, right? There's a lot of money in that. But what about the underlying infrastructure of, as this previous woman mentioned, the DOS versions? It's also a related supply chain issue when most of the supply chain people are using Excel and VBA, or a lot of stuff in China is running on Windows 95. So how are we having talks? And so, but at the same time, when you buy a new iPhone, you're forced to upgrade and not use an auxiliary cord. You have to use wireless earbuds now. And so my question is, I'm looking at those disparities or those gaps in the conversation as we're forcing upgrades on individual personal consumer devices, Fitbits, watches, cell phones, etc. Why are we not matching and having the same standards at the hospital or infrastructural level in terms of software? And are we setting, for example, is there a conversation happening in Congress or about money, or can we start one and invite one about, do we, like we had set carbon emission standards where everybody has to go green by 2023. Are we doing everybody has to upgrade out of DOS by 2030 or something like this? Are we setting standards to keep up with what's happening on the personal consumer side? And I just wanted to bring up that topic because I haven't heard us
Do any
discuss
of
it
you
anywhere.
want to talk about ONC certification and how that advances year by year?
Well, I wasn't going to talk about ONC certification, but I did want to, I think it's a great question, and I wanted to look at it from a security point of view because as a security specialist, legacy systems, legacy hardware, legacy software is the bane of my existence. There's more than a few of these gray hairs come from that. What's driving it from a security perspective is unfortunately the prevalence of security threat actors in the healthcare space. It's become a major target for security assessment or security attacks. And that being attacked successfully and having data breaches or compromises is a very, very expensive undertaking. So there's actually an ROI now to upgrading your hardware, upgrading your software, getting it to a secure version, which may benefit some of these other things as well as an ancillary. It's not a direct answer to your question, but it is kind of a silver lining of the unfortunate environment we find ourselves in a security environment. And then did you want to talk to O&C as well as what they're doing?
So it ends up that the old systems in hospitals are really a drag on the hospital's bottom line in many ways, but one of them is that hospitals are strongly incentivized by CMS and O&C to utilize certified software. And the certification, while we're still talking about the 2015 certification specs, they do advance a little bit with each new O&C rule. And really part of that advancement as of this month is that all certified health IT must support the FHIR standard. They must be delivering that to their customers. And the FHIR standard is built in to all of the new CMS rules in particular for both payers and providers, and there are already FHIR standards for patients being able to access their data directly. So I hear the agitas around old systems not keeping up, but the reality is that they have to keep up or they're going to go out of business. I think we may have time for one more question real quick.
All right, thank you. It's a great panel, by the way. And my question is, and I asked this of Charles yesterday, so I'm told that hospitals are afraid to share data because they're afraid of malpractice lawsuits, right? You share data and then somebody finds out you're consistently making wrong decisions, right? So how do we get hospitals to share data with research?
So hospitals must share data. Providers, there's a federal law that says if HIPAA allows you to share the data and someone asks you for it, you must share the data. So, there is still this sense of, I'm protecting my market, I'm protecting my this or that. Within the information sharing requirements that came out of the 21st Century Cures Act, there are certain exceptions where a hospital, any covered entity, could say, well, I can't share the data because of this. And one of those is infeasibility. The notion that I can't share the data because I can't share the data. My system is down or my system doesn't do that. And I think early on as we get into this new world, there are going to be people claiming infeasibility. I haven't upgraded. But that's only going to hold water for so long. I think people are going to be forced. And we are at time.
Thank you.
Thank you, panel. You guys have been amazing. And thank you all for the great questions.